Today, we are undertaking a pretty critical mission.
I think so.
We're going deep into the neural wiring diagram of the human body. Specifically, we're focusing on something called cholinergic transmission. We were talking about acetylcholine, or AMEC, and why this one single molecule is so often called the master key of our nervous system.
It's a really accurate description, and the sources we've looked at show exactly why. I mean, HE isn't just confined to one little area or one function.
Right.
It operates at three absolutely critical intersections all at once. You've got the involuntary system, that's your autonomic control.
Okay.
Then the voluntary system, so controlling every single skeletal muscle you move. And on top of that, essential processes in the brain like memory and coordination.
So it's everywhere.
It really is. If you look at the whole landscape of neuroscience, you'd be hard-pressed to find another molecule with that kind of widespread and profound influence.
Okay, so let's unpack this. Our goal today is to go a little beyond the basics. We really want to get at the extreme precision and, frankly, the incredible fragility of this entire system.
Yeah.
We need to examine the plumbing, how each is built, how it actually talks to cells, and then how it's dismantled almost instantly.
And that fragility you mentioned, that's the high-stakes part of this whole story.
Right.
When we talk about it, Joe, we're really talking about life and death scenarios. This pathway is a target for everyday prescription drugs, but also for, the most deadly nerve agents ever invented.
And even common insecticides.
So our deep dive is going to follow the molecule's complete life cycle. It really has three sort of non-negotiable stages.
Okay.
First, you have synthesis and secure storage. Then you have receptor interaction, which is the message delivery.
And finally.
And third, the instant and absolutely mandatory destruction and cleanup. If you disrupt any one of those three steps, the whole system it falls into communicative chaos.
So let's begin at the beginning, the assembly line, inside the nerve ending. To get a communication signal, you first need to build the transmitter. So how does the body so efficiently manufacture acetylcholine right where it needs it?
Well, the synthesis pathway is it's really elegant in its simplicity. It all happens locally, right there in what's called the cholinergic nerve ending axoplasm.
Okay.
The neuron takes two building blocks, choline, which you get mostly from your diet, but it's also recycled, and something called acetyl-CoA, which just comes from normal cellular metabolism.
And it just puts them together.
It puts them together using a crucial enzyme. It's called choline acetyltransferase, or a CHAT. And the result is acetylcholine. It's a very direct process.
That sounds like a really smooth, continuous process, but I have to imagine in a system this vital, there must be a point of regulation, a choke point that controls how fast the neuron can actually crank this stuff out.
There absolutely is, and this is a key point of vulnerability in the whole system. While the enzyme, CHAT, is always just sitting there ready to go, the true bottleneck, the rate-limiting step, is getting the main raw ingredient, choline, into the nerve ending in the first place.
So it's a supply issue.
It's totally a supply issue. The cell membrane has to actively pull choline in from the synapse using this dedicated carrier system. It's called the sodium choline cotransporter, and it uses the sodium gradient to power the uptake. So if you slow that down, you effectively starve the entire synthesis pathway.
So if the neuron can't get access to choline, the whole supply chain just grinds to a halt. This specific bottleneck, it seems like a prime target for research, or I guess more nefariously, a weapon.
Indeed. And we have a perfect example of that in the drug hemacalinum, or HD3.
HD3.
HD3 is a specific, really potent blocker of that sodium choline cotransporter. So when you administer HD3, it doesn't stop the enzyme from working, but it immediately halts the inflow of choline.
The factory runs out of parts.
The factory runs out of parts, the nerve ending is starved of its raw material, and the AC8 supply is rapidly and very effectively depleted. It's a perfect pharmaceutical demonstration of how critical that initial uptake step really is.
Okay, so once the ACA molecule is synthesized, it needs to be stored safely. It can't just float around loose, otherwise it would, degrade immediately.
It would, and it would leak out. So it's stored in these secure, customized containers. They're small, clear synaptic vesicles.
Yeah.
And these vesicles, they cluster right near the synaptic membrane, just ready for action. The job of getting the newly made mediation into these vesicles is handled by another specialized carrier called the vesicle-associated transporter, or VAT.
So we have a transporter to get it into the cell and a transporter to get it into the storage vesicle.
Exactly. Two key gates.
And if we can block the synthesis pathway with that AT3, we stop production. What happens if we block this storage mechanism, the VAT?
Well, that's where another drug, the Samicol, comes in. The Samicol specifically blocks the VAT. So if you block the storage step, you're directly interfering with this really sophisticated mechanism of quantal release, because the AC molecules, even though they've been made, can't be packed efficiently into the vesicles.
So you can't get ready for the signal.
Right. It just leads to really inefficient communication, even if all the building blocks are there.
That sets the stage perfectly for the next step.
Right.
Release. The nerve impulse arrives, the signal needs to jump the gap. How does acetylcholine actually get ejected into that synaptic cleft to talk to the neighboring cell?
The release mechanism is, it's maybe the most stunningly precise part of this whole operation. AC is released in these small, fixed, discrete packets. We call them quanta.
Quanta.
Yeah, and the contents of a single vesicle represent one quantum. So when a nerve action potential arrives at the terminal, it triggers an influx of calcium ions.
Okay.
And that calcium influx triggers the synchronous fusion of many, many vesicles with the membrane, ejecting multiple quanta all at once into the cleft. It's a huge burst of synchronized communication.
This burst mechanism sounds incredibly sensitive, which must mean it's also incredibly vulnerable to disruption.
It is.
Our sources detail 2 toxins that target this precise step. But in diametrically opposed ways. This is really where biology meets, neuro-horror.
It's a fantastic contrast, isn't it? On one side, you have botulinum toxin, or BBOT. Most people know it as Botox.
Right.
BBOT is an enzyme that literally chews up the proteins needed for vesicle fusion. It's the ultimate downregulator because it inhibits HE release completely. It just freezes the nerve terminal.
So it's locking the gate.
It is. It prevents the storage vesicles from docking and releasing their contents, and that leads to flaccid muscular paralysis.
So BOT imposes silence by locking the gate.
Yeah.
What about the other side of that coin, the toxin from the black widow spider?
That toxin, alpha-litrotoxin, does the absolute opposite. Instead of locking things down, it forces the gate wide open and jams the mechanism.
Wow.
It causes a massive uncontrolled release of all the HE from the nerve terminals, whether a nerve impulse arrives or not.
So it just dumps everything.
It dumps the entire arsenal, and this initial flood causes intense, painful stimulation, a sort of parasympathetic storm. But because the nerve ending is forced to empty itself so quickly, the system rapidly runs out of a neck.
And that leads to paralysis, too.
It leads swiftly to neuromuscular blockade and eventual paralysis, but from utter exhaustion. It's a perfect highlight of the high-stakes risk of overstimulation.
That dual action is it's mind-boggling. Silence versus catastrophic overload. So let's move to the third and maybe the fastest, stage cleanup. Why is it so absolutely mandatory that acetylcholine is destroyed within microseconds?
Well, it all comes down to signal precision and speed, particularly in skeletal muscle control. Imagine trying to run or catch a ball if the signal telling your muscle to contract lasted for a whole second instead of just a few milliseconds.
It'd be completely uncoordinated.
You'd be unable to perform any rapid successive movements. So to guarantee this high fidelity, the signal has to be terminated faster than the cell can even recover from the first stimulus.
So the cleanup has to be faster than the action.
Much faster. API must be hydrolyzed immediately after it has activated the receptor. This ensures the post-junctional membrane is ready to receive the very next quantum, the very next signal.
And the dedicated cleanup crew for this instantaneous task is cholinesterase. We have 2 major types, acetylcholinesterase, ACE, and butyrylcholinesterase, BUTC. Let's start with the A team.
That's ACE, or what we call true cholinesterase. It's located at all cholinergic synapses, strategically placed right on the post-junctional membrane. It's also found in red blood cells and gray matter.
And its job is just speed.
Its primary function is the ultra-rapid termination of AC action. And when we say ultra-rapid, I mean its turnover rate is one of the highest known for any enzyme. It hydrolyzes AC in microseconds.
Microseconds.
To put that in perspective, the electrical impulse driving the muscle contraction takes milliseconds. The enzyme works orders of magnitude faster than the physiological effect it's terminating.
Which guarantees that motor control is always precise. That speed really underscores the biological need for immediate signal termination. So what about the B team, BUTC or pseudocholinesterase? Is it just secondary?
Well, BUTC is found mainly in the plasma, the liver, and white matter. Its role is less about synaptic signaling. It functions more like a general detoxifier.
Okay.
It hydrolyzes various ingested esters and some drug compounds. And this is where we get a really crucial clinical insight that's often missed in basic texts.
Which is?
Bushi is clinically very important because it metabolizes drugs like the short-acting muscle relaxant, acetylcholine, which is used all the time in surgery.
So this sort of non-specific enzyme has a very specific impact on anesthesia.
Precisely. And you have to consider genetic variability. Some people have a genetically determined sort of atypical form of Bushi.
So their enzyme doesn't work as well.
Exactly. Their Bushi can't efficiently break down acetylcholine. So if they're given this muscle relaxant during surgery, they can suffer from prolonged paralysis that lasts for hours, and they need mechanical ventilation until their body can finally, slowly metabolize the drug.
So knowing the difference between what ACG breaks down versus what Bushi breaks down is critical.
It is. It's critical in emergency medicine and anesthesiology.
The AT tail molecule has now been synthesized, released, and is racing against the clock before AC destroys it. It needs to speak to the target cell. And acetylcholine speaks two fundamentally different languages, defined by the receptors named after the compounds that first helped identify them, muscarine and nicotine.
Right.
What is the core essential distinction between the cellular mechanisms of these two receptor families?
You know, it's really the difference between a direct electrical shock and a slow internal alarm system.
Okay, I like that.
Nicotinic receptors, the N receptors, are the express lanes. They are ligand-gated ion channels. So when ACT binds, a channel opens immediately, flooding the cell with cations like sodium.
And that causes
Instantaneous depolarization,
Right.
a very fast cellular response. This is essential for something like a quick muscle twitch.
and the muscarinic or M receptors.
Muscarinic receptors are that internal alarm system. They're G-protein coupled receptors, or GPCRs. They don't open a channel directly.
So what do?
Instead, when they're activated, they kick off this complex, cascading series of chemical changes inside the cell using what we call secondary messengers.
So the response is slower.
The result is a relatively slow but amplified and much longer-lasting response. They are metabolic, profound, and regulatory.
Let's start with the muscarinic receptors then.
Yeah.
They're the targets for muscarine and famously blocked by the antidote atropine.
Yeah.
We have 5 known subtypes, M1 through M5, but functionally they split into 2 groups based on their G protein coupling.
That's right. You have the activating subtypes M1, M3, and M polys, which are coupled to the GQ protein. And then you have the inhibitory subtypes M2 and M4, which are coupled to the GGO proteins.
Okay, let's detail the activating mechanism for M1 and M3. It's a lot of chemical jargon in the sources, so let's try to make it conversational.
Okay, think of the GQ protein as flipping a switch. When ACH binds, GQ activates an enzyme in the membrane called phospholipase C, or PLC.
Oh yeah, switch flips.
And PLC acts like a chemical splitter, generates 2 really critical secondary messengers, IP3 and DAG.
IP3 and DAG.
Right. IP3 races to the internal calcium stores in the cell and triggers a release of calcium into the cytosol. Meanwhile, DAG stays in the membrane and activates another enzyme, protein kinase C.
So the bottom line is more calcium.
The net effect of this whole cascade is a rise in internal calcium, and that's what drives processes like gland secretion and muscle contraction.
And where does the M1 receptor specifically apply this complex activation?
M1 is primarily neuronal and glandular. We find it prominently on ganglion cells, where it mediates a slow, prolonged excitatory signal. It's also key in the brain for cognitive function learning and memory, and in the stomach, where it mediates gastric acid secretion.
The source material refers to its action in ganglia as a late EPSP. That's a bit technical. What's the significance of a late excitatory signal?
Well, EPSP just means an excitatory signal, something that makes the neuron more likely to fire. Most ganglionic transmission is handled by those superfast nicotinic receptors,
The express lanes.
the express lanes. But the M1 response is slow and late. It acts as a modulator. It prolongs the excitatory state of that neuron long after the initial quick nicotinic signal is gone. It sort of fine-tunes the overall output of the ganglion.
Okay, that makes sense. Moving to M3 then. This one seems to be the main driver for the majority of parasympathetic physical effects.
Oh, it is. It's the ultimate workhorse for secretions and smooth muscle contraction. If you're having a classic cholinergic experience, contracted pupils, bronchial constriction, intestinal cramping, sweating M3 is usually the culprit.
Right.
We find it on visceral smooth muscle, like in your gut and bronchi, causing contraction, and on virtually all your exocrine glands, driving secretion.
But here's the major paradox. M3 causes contraction everywhere else, but if you inject AC, you get massive vasodilation, which is relaxation. Why the contradiction?
This is a beautiful piece of biological engineering. Most of your blood vessels, they actually lack direct cholinergic innervation.
Okay.
However, they do have M3 receptors on the inner layer of cells, the vascular endothelium.
The lining.
The lining. So when circulating AC hits these endothelial M3 receptors, it triggers that GQ cascade, causing the endothelial cell to release a potent chemical messenger, nitric oxide, or NO.
Okay.
This nitric oxide then diffuses out of the lining into the adjacent smooth muscle layer, and that's what causes the smooth muscle to relax and the vessel to dilate.
So AC isn't telling the muscle to relax directly. It's telling the inner lining to release a secondary relaxing agent. That's a really essential distinction.
It absolutely is. And if you were to scrape off the endothelium in an experiment, AC would bind directly to the M3 receptors on the underlying smooth muscle and cause contraction, just like everywhere else.
Wow.
But with that endothelium intact, the nitric oxide release mechanism overrides the contractile effect, resulting in net vasodilation.
Now for the inhibitory side, M2. This receptor is famous for controlling the heart. What's its mechanism?
Two receptors, which are coupled to those GIGO proteins, act as the body's brake pedal. G literally stands for inhibitory.
Okay.
So activation triggers two key effects, both designed to slow things down. First, they open specific potassium channels. This lets potassium flow out, which hyperpolarizes the cell, making it harder for the heart cell to fire an action potential.
And the second effect?
They inhibit an enzyme, adenyl cyclase, which lowers the cellular level of cyclic AMP or CMP.
And the result of all that is vagal bradycardia and slowed conduction, the classic parasympathetic rest response.
Exactly. And we can't forget its role as an autoreceptor. M2 receptors also sit on the prejunctional nerve endings themselves.
So on the cell that's releasing the AC.
Right. Once the nerve releases a flood of AC, some of that AC binds back to the M2 on the very nerve that released it, and it acts as a dampener to inhibit any further release. It's a very clever, localized feedback loop.
The sources really emphasize that recognizing these subtypes allows us to be extremely selective with medicine.
It's the hallmark of modern pharmacology. We have drugs like parenzapine, which is relatively selective for M1, and it was used to suppress gastric acid. More recently, we use agents like darafenacin, which is selective for M3.
And that's used for?
Primarily to treat overactive bladder. By having a drug that targets M3, we can relax the bladder's smooth muscle without significantly slowing the heart, which is M2, or affecting cognitive function, which is M1. Specificity minimizes those unwanted side effects.
Let's pivot to the nicotinic receptors, the fast, direct channel openers. Activated by nicotine, blocked by compounds like tubocurariin or hexamethonium.
Yeah.
Describe the structure of these express lanes for us.
They're magnificent structures. Imagine a rosette that's composed of 5 protein subunits that create a central pore.
That's the channel.
That pore is the cation channel. And when 2 AC molecules bind to 2 specific subunits, they induce this conformational change that just flicks the gate open. Cations flood in, and you get an instantaneous depolarization. They are the absolute epitome of fast neurotransmission.
And we divide these into 2 subtypes based on where they live, NM and NN.
Right. NM is the muscle type. It's found exclusively at the skeletal muscle end plate. These are what mediate rapid muscle contraction. If you block these, you get paralysis.
Which is what certain drugs do in surgery.
Exactly. This is the receptor targeted by neuromuscular blocking agents like tubocurariin, which really revolutionized surgical anesthesia.
And NN, the neuronal type.
NN is the switch for the rest of the nervous system.
Mm-hmm.
You find it in 3 key locations. The autonomic ganglia, both sympathetic and parasympathetic.
Okay.
The adrenal medulla, where it mediates the release of adrenaline, and also in the central nervous system. Blockers of NN, like hexamethonium, are called ganglionic blockers, and they essentially just turn off the entire output of the autonomic nervous system.
So we've established the receptors. Now let's introduce the drugs that act as direct players, the ones that bind to and activate these receptors. Acetylcholine itself is the prototype, but as we've said, it's just too fragile to use clinically.
Right. Acetylcholine itself is the prototype, but by studying its effects, we see the complete blueprint of what a cholinergic storm looks like.
Let's elaborate on the peripheral effects. What is the full spectrum of those wet and slow muscarinic actions we would see if we actually injected SC8?
It would be total parasympathetic overdrive. Starting with the cardiovascular system, you'd see marked bradycardia from the M2 action and a sharp fall in blood pressure because of that widespread vasodilation from M3 on the endothelium.
Okay, so heart slows, blood pressure drops.
Then you look at the smooth muscles and glands. You see intense peristalsis and cramping in the GI tract, leading to colic. The bladder contracts strongly, promoting urination. Bronchial smooth muscle constricts dramatically, causing potentially lethal bronchospasm, especially for anyone with asthma.
And the wet part.
The glands go into overdrive. Sweating, salivation, lacrimation. The patient is, as you said, wet, slow, and cramping.
And what about the nicotinic actions that appear at higher doses?
At higher concentrations, you start hitting the NN and NM receptors. So stimulation of the sympathetic ganglia and the adrenal medulla, the NN action, releases catecholamines.
Adrenaline.
Right. And that can sometimes counter the drop in blood pressure caused by the muscarinic effects, leading to a really complex and variable blood pressure response. At the skeletal muscle end plate, the NM receptor, you get muscle twitching and fasciculations.
But that's brief.
It's very fleeting with native HE because the cleanup is just so fast.
To make these actions clinically useful, chemists developed choline ester synthetic relatives of HE. And the key differentiating factor is their resistance to being destroyed.
Exactly. They are structural modifications that are designed to evade that swift destruction by HE and Buchi, and that gives them a longer therapeutic window. We can even grade them by resistance. Methacholine is only slightly more resistant than atric, but then you get to carbachol and bethanechol, which are incredibly stable. Our sources note they're barely susceptible to either enzyme.
And that chemical stability allows them to be used clinically.
It lets them be administered orally or systemically with a predictable duration of action.
Let's discuss carbachol first. Where is its stability put to use?
Carbachol is used almost exclusively topically in the eye. It has potent muscarinic effects, and also significant nicotinic actions on the ganglia. So it's used to reduce intraocular pressure during surgery or for other ophthalmic procedures.
But we don't use it systemically.
No, we avoid it because of the risk of just uncontrolled cardiac and GI effects.
And bethanechol is the one with the selective clinical focus on the bladder and gut.
That's the one. Bethanechol is a pure muscarinic agent with negligible nicotinic action, and because it's so resistant to hydrolysis, it can provide the sustained push needed for organs that are sluggish but not obstructed.
So things like urinary retention after surgery.
Exactly. It's the gold standard for treating post-operative or postpartum non-obstructive urinary retention and sometimes neurogenic bladder dysfunction. It promotes smooth muscle contraction in the bladder and increases peristalsis in the gut.
But using a muscarinic agonist systemically always invites those widespread side effects we talked about.
It does. A physician has to carefully weigh the benefit of helping the patient void their bladder against the potential systemic discomfort. Colic, diarrhea, sweating, and most importantly, the dangerous risk of provoking bronchospasm. If the patient has asthma, bethanechol is pretty much contraindicated.
Finally, we have the cholinergic alkaloids, the naturally occurring agonists. Pilocarpine is the most significant one clinically.
Pilocarpine is derived from the pilocarpus plant. It's a prominent muscarinic agonist, and it can even penetrate the central nervous system to some extent.
But its main use is in the eye.
Its primary application is in the eye. It is the classic miotic agent used for glaucoma, often as a third-line drug. By contracting the iris sphincter and the ciliary muscle, it physically opens up the drainage angle of the eye, which increases the outflow of aqueous humor and reduces that intraocular pressure.
But what about that distinctive side effect, the spasm of accommodation?
That happens because pilocarpine causes the ciliary muscle to contract so intensely. The eye gets stuck, constantly focused for near vision, which can be quite painful for the patient. It's also used therapeutically to break down pupillary adhesions, often by alternating it with a pupil dilator.
This brings us back to muscarine, the compound that actually names the receptor. It comes from toxic fungi. Our sources highlight that distinguishing mushroom poisoning types is a matter of life or death because the antidotes are completely different.
This is an essential toxicological anecdote. You have to recognize the onset time. The muscarine type of poisoning comes from species like clitocybe or inocybe. It leads to a rapid onset within an hour of severe muscarinic symptoms.
So vomiting, diarrhea.
Intense salivation, all of it. Crucially, if you recognize this rapid onset, the treatment is straightforward. Atropine, given until those peripheral symptoms are reversed.
But there are other mushroom toxins where giving atropine would be a catastrophic mistake.
Yes, the hallucinogenic type, often from Amanita muscaria, contains compounds like muscimol. These cause central effects, delirium, euphoria, severe agitation, with minimal peripheral muscarinic action.
So if you use atropine.
If you incorrectly treat these central symptoms with atropine, which is also centrally active, you risk making the psychosis and CNS distress dramatically worse. You have to use supportive care.
And the worst kind.
The worst are the phalloidin type, from the death cap mushroom. Their toxins cause a delayed onset, 6 to 24 hours, followed by irreversible, massive liver and kidney damage. There's no cholinergic antidote. It requires intensive experimental care.
We've explored the direct actors that mimic ecocam. Now we have to transition to the indirect actors, the anticholinesterases or anti-cheese. These are the agents that don't touch the receptor but instead block the cleanup crew.
The beauty of this mechanism is amplification. By inhibiting Xi, the body's own naturally released AC is protected from being destroyed.
So it hangs around longer.
It lingers in the synapse and is allowed to rebind to its receptors over and over again, not once, but maybe 100 times. And this amplifies every single cholinergic action simultaneously: muscarinic, nicotinic, and central.
And the sources note that certain agents, like neostigmine, have a sort of hybrid mechanism.
That's right. Neostigmine is what's called a quaternary ammonium compound. It's highly charged, so it doesn't easily cross lipid membranes like the blood-brain barrier.
So it's peripheral.
It's purely peripheral. And while its main job is Qi inhibition, it has an additional direct agonist action on the NM receptors at the skeletal muscles. This dual action amplifying AC and stimulating the muscle receptor directly makes it particularly effective for treating muscular weakness.
The chemistry of inhibition is absolutely fundamental here. It's what differentiates clinical drugs from nerve agents. Let's contrast the two major chemical groups, carbamates and organophosphates.
This is a critical distinction, and it's based on the strength and duration of the bond they form with the enzyme. The carbamate, things like physostigmine and neostigmine, they carbamylate the Qi enzyme. They create a moderately strong but reversible covalent bond. The enzyme is inhibited, but over time, water slowly attacks that bond and frees the enzyme.
So it's temporary.
It's temporary. The half-life for recovery is in the range of hours, maybe 30 minutes to 6 hours. It's like temporary superglue.
But the organophosphates, or OPs, the agents used in nerve gas and insecticides, are a whole different ballgame.
They are essentially permanent inhibitors. OPs phosphorylate the enzyme. This forms an extremely strong, highly stable covalent bond. The half-life for the enzyme to recover on its own is measured in days, or in some cases, it's considered virtually irreversible.
So the body has to make new enzyme.
It has to wait for new enzyme protein to be synthesized from scratch.
And related to that irreversible nature, we have this terrifying concept of aging. What exactly is happening chemically during aging?
Aging only happens with organophosphates. After the initial phosphorylation, the enzyme complex spontaneously undergoes another chemical reaction where one of the attached alkyl groups just breaks off.
Okay.
And this process can take anywhere from minutes to a few hours. Once aging has occurred, that bond becomes so tight and stereochemically locked that the enzyme is rendered totally resistant to any attempts at chemical reactivation.
So you're racing the clock.
You are absolutely racing the clock against aging.
Let's connect the chemical nature back to the physiological effects, particularly CNS penetration, which is all about lipid solubility.
Right. If the agent is lipid soluble, if it can easily dissolve in fats and therefore cross the blood-brain barrier, it will cause central effects.
And organophosphates can.
All organophosphates and the tertiary amine carbamates, like physostigmine, are highly lipophilic. They cross the BBB easily, leading to central excitement, convulsions, confusion.
But not neostigmine.
Conversely, the quaternary ammonium compounds, like neostigmine, are large and charged. They're lipid insoluble. They remain purely peripheral in their action, which is a major advantage when you're treating something like myasthenia gravis, where you want muscle action without causing mental fog.
Let's talk about the complex pharmacological consequences of this A-sheet amplification. Starting with the cardiovascular system, why are the effects of anti-cheese described as paradoxical and unpredictable?
Because you have a tug-of-war happening between the muscarinic and nicotinic effects, and both are mediated by AISH.
Okay.
The muscarinic action, M2, is always inhibitory on the heart. It lowers heart rate. But the nicotinic action, NN, powerfully stimulates both the sympathetic and parasympathetic ganglia.
So you have a brake and an accelerator being pushed at the same time.
Exactly. At moderate doses, the muscarinic effects usually win, causing bradycardia. But if the dose is high enough, the generalized ganglionic stimulation can override this, causing a release of catecholamines, which might actually increase heart rate and blood pressure.
So the effect shifts dramatically.
It shifts based on the dose and the underlying autonomic tone of the patient. It requires clinicians to interpret the whole picture, not just one isolated effect.
And what happens at the skeletal muscle end plate when we use anti-SUs? This leads to the physical symptom of twitching.
This is the visual hallmark of anticholinesterase action, repetitive firing and fasciculations. Normally, one quantum of AISH causes one contraction.
Right.
With AISH inhibited, that AISH is sticky. It rebinds over and over to the receptor. This causes the end plate to fire multiple times from a single nerve impulse, resulting in visible, uncontrolled muscle twitching. The system is hyperexcitable.
But if the dose gets too high, that hyperexcitement leads to paralysis. Explain that depolarization block simply for us.
Okay, think of the muscle cell as a car engine, and the nicotinic receptor is the accelerator. When a signal arrives, the accelerator is pressed, causing contraction. When the cleanup crew, ACE, does its job, the accelerator is immediately lifted and the car is ready for the next press. When you inhibit ACE-B, the accelerator is pressed, but it gets stuck in the fully on position. The muscle cell stays fully depolarized and excited. But a nerve cell that is constantly excited is actually non-functional.
It can't reset.
It cannot repolarize to receive the next distinct signal. This persistent, fixed depolarization is the depolarization block, and it results in flaccid paralysis.
It's functional failure through overwhelming saturation.
Precisely. And in the case of organophosphate poisoning, this is the main cause of the dangerous respiratory paralysis.
Let's bring all this theory into the real world, starting with myasthenia gravis, or MG, an autoimmune disorder that requires the precise application of these anti-Ts.
MG is defined by weakness and easy fatigability. The immune system mistakenly attacks the patient's own NM nicotinic receptors at the neuromuscular junction, drastically reducing their numbers, sometimes down to just 20% of normal.
So the nerve is fine, the ACH is released fine, but the receiving mechanism is just crippled.
Exactly.
So if the receptors are depleted, how does an enzyme inhibitor help a patient with MG?
It's an efficiency strategy. We can't regrow the receptors instantly, but we can make the transmission far more effective. We use long-acting peripheral anti-Ts like pyridostigmine or neostigmine.
And by inhibiting the enzyme.
By inhibiting AC, we ensure that the small amount of aceclidine that is released is sticky and durable. It lingers, repeatedly interacting with the few remaining receptors until a successful action potential is triggered in the muscle. We're just maximizing the impact of every single AC molecule.
This treatment requires really careful titration, since the patient's needs can fluctuate. And this brings us to a life and death diagnostic scenario, distinguishing between a myasthenic crisis and a cholinergic crisis, both present as muscle weakness, but one needs more drug and the other needs less.
This is one of the most stressful clinical decisions. A myasthenic crisis means the weakness is due to undertreatment. The AC signal just isn't strong enough to overcome the massive receptor loss.
So they need more of their medication.
They need their anti-Chi dose increased immediately. But a cholinergic crisis means the weakness is due to overtreatment. The patient has too much drug, leading to that massive saturation and depolarization block we talked about, the stuck accelerator. Increasing the dose here would be fatal.
So how is this high-stakes differentiation performed in real time?
With the edrophonium test, also known as the tensilon test. Edrophonium is an anti-Chi, but its duration of action is extremely brief, only about 10 to 30 minutes.
A diagnostic dose.
It's a small diagnostic dose. The clinician injects it. If the patient's muscle strength rapidly improves, it confirms they were suffering from a myasthenic crisis. They were underdosed, and they desperately need more long-acting medication.
And if they get worse?
If the patient worsens or shows no change, it confirms a cholinergic crisis. They're overdosed. They need an immediate reduction or withdrawal of the anti-Chi and supportive care.
That is a critical tool for safely managing MG. Beyond muscle weakness, what other major therapeutic applications do anti-Chis have?
The second major area is in the brain, treating Alzheimer's disease. AD involves progressive degeneration, including the specific cholinergic neurons that are responsible for cognitive function.
So the idea is to boost the remaining signal.
The rationale is to augment the dwindling cholinergic transmission in the brain. And since these drugs have to reach the CNS, we use centrally acting lipophilic anti-Chis, donepezil, rivastigmine, and galantamine.
So the goal is to stabilize cognitive decline by boosting the remaining HE in key memory centers.
Exactly. They offer symptomatic improvement, often stabilizing function or slowing the decline for months to a year, but they are not a cure. And the dosage has to be titrated very carefully because crossing the BBB means you risk those central muscarinic side effects like confusion or excitement.
And we noted the use of physostigmine as a specific antidote in toxicology.
Yes, physostigmine is the historical antidote for anticholinergic poisoning like from an overdose of belladonna alkaloids such as atropine or tricyclic antidepressants.
And because those cause central and peripheral symptoms.
Right, you get tachycardia and dry mouth peripherally, but you also get severe central symptoms like hallucinations and delirium. You need an antidote that can reverse both. And physostigmine, being a lipophilic carbamet, crosses the blood-brain barrier and reverses both the peripheral and central toxic effect.
Which neostigmine couldn't do.
If you tried to use neostigmine, it would only work peripherally, leaving the patient delirious and convulsing.
This brings us to the most dangerous application of this chemistry, anticholinesterase poisoning, usually from high exposure to agricultural organophosphates or, terrifyingly, nerve agents.
This is a devastating, chaotic clinical event. The symptoms are just a messy, all-out war in the nervous system, combining all three cholinergic effects at once.
The muscarinic effects
Are overwhelming. Pinpoint pupils, severe bronchospasm, copious bronchial secretions, vomiting, diarrhea, all the wet symptoms. The nicotinic effects start with muscle fasciculations, which rapidly progress to total flaccid paralysis, especially of the respiratory muscles.
as the central effects.
And because OPs are lipophilic, you get profound central effects. Confusion, convulsions, coma.
And the patient usually succumbs to respiratory failure. The treatment requires a very specific two-pronged approach. Let's focus intensely on the primary antidote, atropine.
Atropine is the immediate, non-negotiable primary antidote. It is a muscarinic antagonist. It works by blocking the overwhelming ACA at all the M receptors.
So it dries up the patient.
It reverses the entire muscarinic syndrome. It dries up the secretions, reverses the bradycardia, and halts the bronchospasm. And you might need massive doses to override the central muscarinic symptoms as well.
But the critical limitation here must be stressed. Atropine doesn't fix the muscle paralysis.
Absolutely. Atropine saves the patient from drowning in their own secretions and protects the heart. But because it's a muscarinic antagonist, it has absolutely no effect on the nicotinic receptors, the NM receptors, which are responsible for that peripheral muscle paralysis.
So the patient is still at risk of suffocating.
They are still vulnerable to suffocating because their diaphragm and intercostal muscles are blocked. They need assistance to breathe, and they need the second antidote.
Which is where the oxymes, like palidoxime or 2PM, come in. This is the adjunctive treatment used only for organophosphate poisoning. How do these compounds reverse that toxic bond?
Palidoxime is a chemical reactivator. It has a high chemical affinity for the phosphorus atom that has latched onto the Chi enzyme. It essentially acts as a chemical wrench.
A wrench.
It positions itself on the enzyme and then it pries the organophosphate group right off the active site, thereby physically restoring the enzyme's ability to hydrolyze ACLE. This reactivation is what restores normal function at the neuromuscular junction and reverses the nicotinic paralysis.
But this is a race against the clock because of that aging process we discussed.
It is the ultimate race. Palidoxime must be administered quickly, ideally within the first few hours, before the phosphorylated enzyme ages and becomes permanently resistant to reactivation. If the enzyme has aged, palidoxime is useless.
And finally, the life-saving distinction. Why is palidoxime strictly contraindicated in carbamate poisoning? This is a really high-stakes clinical detail.
It is. It's a double-edged sword that could kill the patient if it's misapplied. Carbamates, like neostigmine, cause reversible inhibition. When you try to use palidoxime, it's just ineffective against that carbanylated enzyme.
But it's worse than just ineffective.
It's more dangerous than that. Palidoxime itself possesses a weak anti-Chi action. So if you give palidoxime to a patient with carbamate poisoning, you are simply adding more anticholinesterase activity to a system that's already overloaded. You're worsening the cholinergic crisis.
As the rule's clear.
Palidoxime for OPs to reactivate, atropine and supportive care for carbamates.
That distinction just highlights the absolutely fine line clinicians walk when diagnosing and treating acute poisoning. And as a final note, we should probably mention the delayed toxicity associated with chronic OP exposure.
It's a chilling reminder of the lasting impact of some of these chemicals. Some fluorine-containing organophosphates can cause a delayed polyneuropathy, a severe nerve degeneration that occurs days or weeks after the acute exposure has resolved.
And this causes.
It results in progressive lower and upper motor neuron paralysis that can be devastating and chronic. And crucially, this delayed damage is completely separate from the qi inhibition mechanism. There is no known antidote, and recovery, if it happens, can take years.
This has truly been a deep dive into a system that is just defined by its precision, from the active uptake of choline to the instantaneous destruction of the signaling molecule.
We've seen how fundamentally important the cholinergic system is. We can target its synthesis to deplete supplies, target its release for paralysis with Botox, and target its destruction to treat muscle weakness with anti-Qis.
Understanding this balance allows us to stabilize the heart, restore gut function, and even reverse the catastrophic effects of poisoning.
It's incredible, really.
Our entire conversation has, necessarily focused on the peripheral subtypes M1, M2, and M3 because they govern all the motor, cardiac, and secretory functions.
Right.
But the source material leaves us with a really provocative note about the two subtypes we largely ignored. M4 and M5, which are largely confined to the central nervous system.
They are the frontiers of research. While M4 is often linked to inhibitory control over movement, the M5 receptor is particularly fascinating. It's noted that M5 facilitates dopamine release in critical brain regions.
Dopamine release.
Yes, mediating reward behavior and potentially influencing areas linked to psychosis.
That opens an enormous door. If we can target these non-peripheral receptors without causing the catastrophic muscarinic side effects like bronchospasm or bradycardia, the clinical possibilities just explode.
Exactly. Our current Alzheimer's drugs are, well, they're blunt instruments. They boost AC generally. But consider the implications if medicinal chemists could develop highly selective agonists or antagonists that target M5 specifically. If this receptor truly mediates reward pathways, could selective M5 modulation offer a totally novel approach to treating addiction? Or perhaps rebalancing the dopamine system in psychiatric disorders like schizophrenia or severe depression? The master key of ACA still holds major secrets in the central nervous system, and M5 might just be the lock that future medicine tries to pick.